Welcome everybody to our webinar this evening, one of our Talking Treatments webinars called today we're focusing on HPV, head and neck cancer, and how to beat it. So really delighted to have two really excellent guests with us this evening. The first is Dr. Elizabeth Marsh. She's one of our Oracle funded researchers, proudly part of our Oracle family. She's a senior lecturer at the University of Derby, and she's leading a team that are doing some very interesting, we call it basic science. I think it's more exciting than basic science into the HPV virus. She'll tell us all about that later. We also have Steve Bergman with us today. Steve, it's hard to encapsulate Steve in one sentence, but he's an educator, he's an actor, he's a campaigner, and he's also a dog owner. But he's here this evening because he has successfully been treated for head and neck cancer, HPV cancer, 6 years ago. So Steve's going to be telling us a bit about his experiences. We'll hear from Elizabeth about the research that she's doing, and then we'll have a conversation at the end, so we're just pulling it all together. So I'm going to crack on. Steve, you may mute yourself. I give you permission.
Thank you.
Greetings to you from the South Coast. Where are you today?
I'm in St Leonard's. I moved here 4 months ago from Walthamstow in London.
Oh, bit of a change, isn't it?
Absolutely.
Yeah.
And hi everyone. Hello everyone.
So it's fab to have you here tonight, Steve. Somebody might recognise you, not just from your sort of acting work, but from your reading that you gave us at Glory at Christmas. That was you sort of wrote that, didn't you? It's like a dramatised bit of your story, I suppose.
Yes, I did, and I was when Sarah asked me to write, I thought I really don't want people to sound. I don't want it to sound horrible because it was Christmas and all that kind of stuff. So I just came up with the idea of a sort of, a narrative that had a part of a children's story in it, and yeah. So I enjoyed writing it actually.
Oh well, I certainly loved watching you perform it. So thank you for doing that. I mean, so you told a little bit of your story there, but it'd be great if you could just, fill in the good people of this webinar about a bit more about yourself. So, how old are you, roughly, if you don't want to give details, and how has this last year or so been for you?
It's been, right, so Steve Bergman, I'm 62. I was diagnosed with head and neck cancer on the 8th of May 2015. It's very big in my head. It was also election day that day, and it was very memorable. So kind of right. So yeah, and up to that point, I'd been working as a behaviour specialist and therapist, and I'd actually given my notice in and was leaving work at the end of that summer term, and I was going to be returning to something that I did 25 years earlier, which was returning to acting and being an actor, and then the horrible cancer happened. So that it didn't completely interrupt, but I was then for 6-7 months, and I recognise that I was very lucky and I recovered very quickly. I just was laid out, and it was just dreadful. Just trying to think, I guess. So yeah. So
what were the first signs for you, Steve? Because you've talked about how you were really active, very fit, cycling everywhere.
Cyclist and runner for years, no non-smoker, really not very much drinking at all. I was asked the other day by a dentist if how much alcohol I drink, and I said 2 to 3 units a week, and that's the truth. Because I'm really not much of a drinker. So what happened was that from about December to May, I had a run of colds that would there never seemed to be a break. I'd get this streaming cold and a really sore throat, and then there'd be a relapse, and then I'd get a break, and then it would come back again. And it was about 3 or 4 colds in nearly 5 months. I went to see my GP. First of all, I was given I hadn't had antibiotics for absolutely years. Was given 2 lots of antibiotics. They clearly weren't working. I was one of the symptoms used to drive my wife mad was I'd be eating food and I'd start coughing it up, and it was almost as if it was getting stuck. And Jackie would say to me, "Oh, for goodness sake, just go and have some water." And she just thought I was being really dramatic. She keeps me well grounded. And then I went back to my GP and said, "Look, none of this is working." And then I happened to mention that I was getting a pain down the side of my neck. And clearly alarm bells went off for him. And he said, "Right, I'm going to refer you to ENT, to your local hospital." I was referred, and within a week, I was seen by the ENT consultant who stuck shall I continue? Shall I keep going, Teresa? So he stuck a camera down my neck, and then he nose and down the back of my throat, and he sat me down and he said to Jackie and I, "We need to be speaking about cancer." And within a week, I was in hospital having what I thought was going to be a biopsy, so going to be in the operating theatre for an hour. I woke up 4 hours later with a tracheostomy in my neck, and I was being trolleyed off to intensive care and I couldn't speak at that point, spent 2 to 3 days in intensive care. And then
that sounds like it must have been a huge shock, Steve.
Well, it was, and the consultant was absolutely brilliant, and I still have contact with him. He had only mentioned in passing the possibility of a tracheostomy, and the reason why he placed this in there was because when he went inside to do the biopsy, there was so much mass in there of cancer that he felt that, and he cut it away, he felt that I might get some swelling. So the tracheostomy was there as a precaution, so that if I did get swelling, that I would be able to breathe.
Oh, okay. So within a week, you've gone from alarm bells ringing with your GP to being in intensive care, being sort of cared for after your surgery. So what happened after that? Was that the end of your treatment, or did you go on?
No. So then I was in hospital in all for 10 days, moved to the high dependency ward, where I kind of, and I've been very fit and healthy, runner, cyclist, and was just so determined that that tracheostomy was, to begin with, impossible to manage. But I was determined I was going to manage it, and started eating and recovering, and was slowly getting better in hospital. Then after 10 days, they released me, and I was back in the community, where the whole, I always call it that I always phrase it in that I became the property of the NHS. I just handed myself over to them, and I was quite numb, I have to say. And whenever I received information, it was really difficult for me to digest it. Unfortunately, I've got a partner and wife who is really sharp and bright, and if something was said, she would go away and research it, and that was just the best thing. But I was kind of very much living in that moment, that day to day, what's the next step? And then the next step for me was chemotherapy. So I started intensive 6 weeks of chemotherapy, a break, fitted for a radiotherapy mask, and then when I was feeling better from the chemotherapy, I then started 6 weeks of intensive radiotherapy with chemotherapy as well. So
that's really very full on and intensive treatment, isn't it?
Yeah, so in all, it was probably 14, 15 weeks of operations, recovery, treatments, and all of the side effects. And for those who are listening now, and this will chime for you, the whole thing about the massive ulcers in the mouth, which, I mean, not just a simple spot, but just burning ulcers, no swallow, saliva. I had a peg in my stomach, loss of taste. Some will say I've got no taste at all, and just everything just closed down, and it made me realise. And I had stage 4 HPV throat cancer. I had a tonsillectomy, and it made me realise how busy this area of the body is. It's really got so much going on. But yeah, and then when the treatment stopped, then it was trying to get on with recovering.
I mean, that's like a huge job in and of itself, isn't it? But what I might do is just pause here for a moment, Steve, if that's okay, and we'll ask Elizabeth, Dr. Elizabeth Marsh, to join us now. Just talk a little bit, because Steve's diagnosis was a stage 4 HPV squamous throat cancer. So, and Elizabeth, your work is focused very much on HPV-driven cancers, isn't it? Can I ask you to introduce a bit about what you're doing? And
yeah, absolutely. And I have some slides prepared as well to accompany the science. So I'll attempt to share these now. It did work in the practice, but whether, of course, it works in the real situation is a different matter. So it's that one. There we go.
That has worked beautifully.
Yeah, excellent. Alrighty. So yes, good evening, everybody. I'm going to tell you a little bit about the background to Steve's disease. I'm not a clinician. I am, as we term ourselves, a basic scientist, and Teresa pulls me up on that and says, no, I am a fundamental scientist. And then I'm going to talk to you about the project that we're doing that has been funded by the Oracle Cancer Trust as well. So the theme this evening is human papillomavirus. And these are very small DNA viruses of the Papillomaviridae family. They cause a range of papillomas, and I expect that most of us will be familiar with them as having warts on our hands, verrucas on our feet when we were much younger. But they also cause genital warts as well. Those viruses are found everywhere across the world, and there are over 160 different viral types that we've described, and they're all represented here in this image of they're all labeled sort of HPV and then a different number. Now, most of these infections are very low risk. Some of them you wouldn't even know that you had the infection. They cause no symptoms whatsoever, and others, as I've already said, you have your warts or your verrucas on your feet, and your immune system will control those, or perhaps you'll need a bit of a helping hand with an over-the-counter treatment that you dab on, and then that clears. But over around 15 viral types are considered to be what we call high risk or cancer causing, and 2 of those viral types are called HPV 18 and HPV 16, and we currently vaccinate children against these types predominantly because we know that they are the cause of cervical cancer, and I expect that is where most people would be familiar with a relationship between human papillomavirus and cancer as the cause of cervical cancer. Now, even these high risk or cancer causing viruses are generally cleared by our immune system. So we'll have an infection, but we fight it off pretty easily. And we don't get cancer, we have no symptoms, you know, we don't know that there's ever been an infection. But there are some instances where these infections will persist and the immune system is unable to clear that infection. And unfortunately, this persistence allows those viral proteins, part of the virus itself, that interfere with our normal cellular function, and that will ultimately lead to the development of cancer. Now, although, as I've said, HPV is classically known to cause cervical cancer, over the past 20 years or so, the prevalence of HPV in the cervix has actually been decreasing. We have a very efficient screening program for that, and we have been vaccinating young girls since about 2018. Now, on the other side of that, the incidence of head and neck cancer has been increasing in the UK and across the world. And these are oropharyngeal squamous cell carcinomas, or you'll see on the slides a lot OPSCCs, and these arise predominantly, as Steve has already mentioned, actually in the tonsil and also in the base of tongue. And obviously with this increasing incidence, this has been investigated, and we now know that these are associated with HPV infection. And indeed, in 2017, the World Health Organization declared HPV as a distinct cause of head and neck cancer. So what do we know about oral HPV infections? If we look at healthy tonsils, so these are not cancerous tissues, the prevalence of HPV in the mouth is around 11.5%, as it says on this slide. Now, obviously, this is just one study, and there are quite a few in the literature now, but generally it's kind of believed to be about 20%, under 20%. Of the population, but I mean, the 20% prevalence is still quite a lot of people with oral HPV in their mouths. What this particular study shows that I have put on the slide is that there's a real difference in these infections between men and women. Men have a much higher prevalence of oral HPV, and they are actually 6 times more likely to be infected with one of those high risk or cancer causing types, HPV-16, than women. And we now know that about 40 to 60% of oropharyngeal squamous cell carcinoma are HPV positive, and there are some publications actually in the literature that are even suggesting that it's 75% of the cancers at this location that are HPV positive. HPV is a sexually transmitted infection, so these infections occur generally when we're much younger and then persist, as I've mentioned. So it's many years between that initial infection and then the onset of disease. The presentation of these cancers is typically in men. They are younger than kind of conventional head and neck cancer, if you like. And as Steve again has already described, they don't tend to have this history of alcohol use or smoking, which again is so associated with that more kind of classical head and neck cancer, if you like. So it really is a sort of distinct disease. HPV-16 seems to be responsible for about 90% of HPV positive head and neck cancer. But we also have found that individuals who have HPV positive disease seem to be responding better to treatment than those with conventional HPV negative disease. And why is this? I mean, is it because, as Steve has said, you know, generally these individuals are fit, they're younger? Is that a reason why, or is it sort of more to do with, say, the virus, in terms of in a classical cancer, we have various genes in our cells that are protective, and in cancers they are mutated generally, whereas in an HPV positive cancer they have actually been suppressed by the virus itself. So they're still there. So if when we start to treat, are things able to reactivate? Is the cell in the body able to respond much better? And is that the reason why we seem to be seeing this improvement in treatment for individuals with HPV positive disease? And so as a result, there are a number of clinical trials now that are looking at de-escalating that treatment, so reducing a radiotherapy dose. There's some promise there. And there are some novel immunotherapy studies as well in clinical trials, and I'll probably mention those a little bit later in the discussion that we have. As I've already mentioned, the vaccination program was introduced in, I think I said 2018, actually, that was completely wrong, 2008. And it became a gender neutral program from September 2019, when we now vaccinate boys as well as girls. And this vaccination program has been hugely efficacious in reducing the incidence of cervical cancer. And there is promising evidence for the same for oral infections, but obviously the impact of that will come over the coming years. So what about now? Well, the situation today is that the clinical burden of HPV positive disease is around 29,000 global cases per year. And that simply, we do not know how HPV causes oropharyngeal cancer. We believe, as I've already said, that HPV infections establish in the tonsil, and this is certainly where the tumours originate. And obviously there is going to be a multi-step process of some description from the tonsils to D, which is a cystic metastases. And this is how we see individuals presenting in the clinic. And very often they present very late. They don't present with early disease, they present with late disease. And as I've already said, we know that there's a higher disease burden in men, both in terms of the disease and the infections, actually. And so sort of all of that together, there are things that we know. There are a hell of a lot of things that we do not know. And we have some fundamental questions, and I've listed those on the slide, that we hope to understand. And the way that we propose to do this is to understand the biology of the virus in those tonsils, the tissue in which that infection presents. Now, the sort of theory for that is because our understanding of HPV causing cervical cancer has been so informed by understanding the biology of the virus within the cervix. And we hope to apply that same sort of approach and therefore understand the virus behaviours within the mouth. And hopefully that will help us improve the clinical outcomes for our patients with HPV positive oropharyngeal disease. So our study, which was funded by the Oracle Cancer Trust and started in January this year, sets out to understand that virus in order to allow us to understand the disease. And we intend to investigate what we call the natural history of the virus. That's kind of a way of saying the behaviour of the virus, I suppose, the prevalence, the pathogenesis, the life cycle of that virus within healthy tonsil tissues. So this is a non-cancerous setting. Now, there is a little bit of a caveat there, because obviously we're not going to bring people into the hospital and just whip their tonsils out a bit kind of willy-nilly. So these individuals do have some sort of recurrent infection or inflammation that means that they have been referred for a tonsillectomy. So they're not healthy, but they are not cancerous, and that is a requirement of an inclusion factor within our study. But these, as I've already said, are the tissues in which those infections and tumours establish. And so we intend to understand what the virus is doing there, first of all. And then we will go on and utilise a really specialist technique called swath mass spectrometry. And we will use this to identify a series of very specific biomarkers in HPV positive tissues. And these biomarkers will represent fundamental cellular changes within those HPV positive tissues that are due to oral HPV infections. And these markers will increase our understanding of viral pathogenesis, but they will also offer novel targets for a potential for improved diagnostics or therapeutic approaches or interventions. So our study is based in the East Midlands, and we have a team of scientists such as myself, as well as clinicians who will undertake this work. We're based throughout the region, the universities of Derby, Aston, Nottingham, Trent, and then also the Royal Derby Hospital, Queen's Medical Centre, Nottingham, and Leicester Royal Infirmary as well. And the involvement of these big hospitals that have very big catchment areas should provide a kind of sufficient representation of the population for our study to have both national and international implications. So what do? There's a gross picture coming up, I apologise. Our project makes use of healthy, non-cancerous tonsils, as I've already described. So yeah, that's what comes to us from the hospital. And we also require our participants to complete a lifestyle questionnaire and also to take an oral swab as well. So that's all collected from consenting individuals who are having their tonsils taken out as a matter of routine. And what we think is really special about using these tissues, rather than, say, using a sort of more controlled system within the lab, is that by having that lifestyle questionnaire, we can understand a little bit more about the relationship between our behaviours, our lifestyle behaviours, and what is happening with the virus in the mouth. So we can look at the implications of alcohol, of smoking, of sexual behaviours, of gender, and relate that to the pathogenesis data that we are also collecting. So as I've already mentioned, we screen our tonsils for the presence of HPV, and then if it's there, we will start to look at things like viral load and the expression of specific viral genes that we know are involved in driving cancers. And then that screen will allow us to define a cohort of HPV positive and HPV negative tissues that we will analyse using the swath mass spectrometry approach that I've already mentioned. And then we hope to relate this to the oral swab and see if there is any way that we can pick up those same markers, that same panel that we've identified through the mass spectrometry approach within an oral swab. And, you know, is there then some sort of potential for a screen for disease, or a way that we can stratify patients so we know how to treat them, that sort of thing. And then obviously, as I've already mentioned, we'll relate all of that data back to the lifestyle questionnaire and look to see if we can define any cohorts that might be at risk or higher risk of HPV positive disease. And this is just an image that was collected very recently from my PhD student who's in the audience today. She's really the one that does the work. I get to do this sort of thing, but she's the one that's slaving away in the lab. And this is just some raw data that she's pulled off the machine. And what she's showing here is that different sections of the tonsil, so you can see they're labelled sort of S1 through to S5, and we have a couple of controls in here to make sure that the experiment that we're running is working as we expect it to do so. And she's showing that some sections, so for instance, section 1 and section 4, are producing a really nice peak that's kind of mimicking what we call our positive control, which is the virus within a plasmid, so a very artificial system. Whereas section 5, down at the very bottom, we're not seeing a signal there. So we would interpret that to be HPV negative. And so, yeah, she's showing that the same tonsil is in different parts, positive and negative for HPV. And this is the sort of data that she's going to be pulling together over the coming weeks and months before she moves on to the additional analyses as I've already discussed. So we hope that our study will improve the outcomes for individuals with HPV-mediated head and neck cancer in 3 ways: informing therapeutic approaches, improving diagnostic tools, and also through education. We believe that our increased knowledge and that the whole scientific community there of the biology of HPV within the tonsil will inform the adaptation of current treatment regimes. As I've mentioned, that's with de-escalation, but also that the biomarkers that we describe will offer novel drug targets for new medicines to be targeted against, or medicines that are already there that can be repurposed for HPV positive head and neck cancer. As I've already briefly outlined, we'll attempt to use that same biomarker panel as a screening tool. It could be, say, part of a multi-diagnostic approach for individuals with HPV-mediated disease, or potentially it could be used to monitor or manage sort of cohorts that are at risk of this infection. And we also aim to identify who those cohorts are through this project as well, through all of the information that we are gathering. And then of course we can target those cohorts with public health campaigns, for instance, or you know, monitor them perhaps a little bit more closely, maybe improve relationships with their dentist or what have you. We absolutely want to raise awareness of this disease. It's really not very well known, and we now have, as I've mentioned, this vaccination program for boys, and we really want to engage boys in that vaccination program and get them taking that up as well. So in order to do that, we will continue, obviously, our work with the Oracle Cancer Trust, but also HPV Action, the Swallows Head and Neck Cancer Charity, and the British Dental Association to disseminate our research findings, both to clinics, clinicians, and to the wider public as well. And ultimately, we hope that by understanding the virus, understanding what it does in the head and neck prior to the onset of cancer, we hope to reduce the significant morbidity and mortality that Steve has been discussing with us. I mean, obviously, it's wonderful that Steve is here, but he's been through a horrendous time in these past few years, and this virus is not nice, and our aim is to improve outcomes for individuals with HPV positive disease.
Thank you so much, Elizabeth. I know you've condensed an awful lot of science into just a few minutes presentation, so I really appreciate it. And I actually understood what you were talking about as well, which is rather nice for a science presentation. Really appreciate it. I thought it'd be a good thing to do now would be to bring Steve and Elizabeth in on a conversation, really, because Steve, you've got your recovery story to share. Actually, Elizabeth, as you said, you know, Steve had been through quite a incredible experience, actually. So, yeah, Steve, could you tell us a bit about how you know what was recovery like for you? What did it look like? What did it entail?
Right. Okay. So, I mean, again, it's really interesting listening to Elizabeth, but so I told you part of my story, which is how I was diagnosed and the treatment program. What I'm really aware of, that my physical recovery probably took about a year, and that's fairly quick for somebody who went through what I went through. I'm really aware, and I was talking to a fellow actor only the other week about the fact that he no longer has proper saliva glands that are working. So he's become limited in his work opportunities. I feel incredibly fortunate in that everything that came back, everything that should have come back and returned, did. And to the point where I was told I would never be able to grow a beard, and everything has come back. And bit under there doesn't work. Yes, so there was that. And so I'm really very, very fortunate. What I didn't say earlier was that as soon as I was diagnosed, being in the creative world, what I did, and I didn't quite get why I did it way back then, 6.5 years ago, was that I got a director and a cameraman in, and I started to record my progress through the whole experience. And we put together a short film, and I put it out on the web and sent it off to a few cancer charities, HPV cancer charities. And then I was approached to make a 5-minute film supporting the vaccination for boys, because in that whole thing about I didn't connect cervical cancer with the cancer that I had. And I have to say, not promiscuous, but I'm a grown straight man, grown up sometimes, straight man, and I just have lived life, and I got this HPV cancer, and it had just happened, and it's no moral judgment or anything. And what I've noticed over the years, there's not very many men of my age who are prepared to be open about this.
And Steve, do you think, I mean, you've sort of alluded to it really, do you think sort of being a campaigner and taking steps to improve the situation and raise awareness helped you with the other side of your recovery?
Absolutely.
Emotional.
What I've realized over the 6.5 years, I've now been signed off. I am completely recovered, and have been told that I'm unlikely. I mean, the chances of this coming back are highly unlikely. The chances of getting another cancer are probably more than this returning. But what I realized now what I had to do was that I had to do stuff, because this was so big. I had to do equally big stuff that was positive. And it's been part of my therapy, because the physical recovery for me was fairly quick, because I got up back on my bicycle and started running again, and was just determined to get back to where I was. But the emotional impact was enormous, and that I sought my own therapist, and when my therapist, I used to get surges of this enormous anxiety. And it was, I'd be cycling to work, doing the freelance work, cycling to work, and going across the Olympic Park, and all of a sudden thought would come into my head, which would lead to another thought, and then I would get a surge of uncontrollable anxiety, something I'd never experienced before. It wasn't about fear of dying. I couldn't put my finger on it. It was just complete anxiety. I found my own therapist who said to me, and when he did this, it just helped enormously. He said, "You are suffering with post-traumatic stress. Your experience is so extreme. This is what's happening." And what happened with the campaign, that 5-minute video, was that I was horrified. My daughter, who is now 27, she was the first year in 2008 to be vaccinated. And then when I was told that actually there's a whole campaign about boys not being vaccinated, and the herd immunity, the government's line was herd immunity would actually mean that boys wouldn't get HPV cancer. It was just ridiculous. It's just absurd. As we can see with COVID, there are all kinds of debates about when herd immunity kicks in. And it's absurd, it's ridiculous. So that was what that opened me to the world of campaigning, and I've written articles about this. I've been on TV about it. I have even rode across the Mediterranean Sea, not single-handedly, I have to say. And actually, I have to say, I was also there in Parliament when the JBCI and the Select Committee were there discussing it. And I was cited as an example. And it just makes me realise that what I have been doing over the years and working with different cancer charities and involved, as Elizabeth said, through that education, that I'm part of a number of programs that are being put together that are being rolled out to schools, because people are still reluctant to really engage with it. In 2019, I did a whole series of radio interviews, local radio across the country. And every one of those hosts on the radio kept saying to me, so what would you be saying to the parents of those boys who are going to be vaccinated? And I just said, do it, because the misery that somebody goes through 30 years later, that will be reduced. The fact that 5 years ago, the government was spending £40 million on genital warts to get rid of genital, not on genital warts, to get rid of genital warts. They could have 6, 7, 8 years ago started giving boys the vaccination, and genital warts will just go. It will just save money. Anyway, that's it. That's me.
Oh, well, Steve, it just sounds like you've sort of bundled up all of this experience you've had and tried to turn it into something really positive. And I know that you have had a big impact. You've mentioned something about the vaccination program, Elizabeth. I wondered if you had any comment on it, because you joked about me pulling you up about being a basic scientist, and I think is it Eleanor who's your researcher, who's here today. But why is it that HPV in head and neck cancer, our understanding is so far behind in cervical cancer?
I don't really know the answer to that. It has only been in more recent years. I mean, I know that I've said sort of in the past 20 years or so, the incidence has been increasing. But there is always a delay of recording this sort of thing, and then actually sort of noticing, hang on, that's a trend. Perhaps we need some sort of intervention there. Whereas, of course, cervical cancer was described much longer ago, and very much the kind of one cause effectively is HPV is responsible for 99% of cervical cancer, where head and neck cancer is many different diseases, and HPV positive oropharyngeal squamous cell carcinoma is a fraction of those. So I mean, head and neck cancer kind of collectively is one of the most common cancers, and yet one of the most underfunded and sort of under-recognized cancers. And as Steve has said this evening, that sort of recognition of everything that happens here, and yet we almost don't seem to be prioritizing it, if you like. So I can't really answer that question as to why it hasn't been on the agenda. But things like that Steve is doing, that we're doing, hopefully we'll change that story. In terms of the HPV vaccination program, I am obviously in full favour of that. And I've seen that there have been a couple of questions in the chat about that vaccination program, and does it remove the entire risk of oropharyngeal cancer? We just simply do not know yet. We don't have that data. We have been very much looking at how effective it is at cervical cancer, and that is there. So these data are beginning to come through now, but the impact on the male population will be for years to come, as they mature, and then do we see this reduced incidence? So at the moment we don't know. We don't have those data. And then the question from Robert, I'm really sorry to hear that of your diagnosis. Yes, it isn't 100% effective, but my feeling there is that you were only unfortunately vaccinated 4 years ago. And as I said in my talk, these infections establish years before your diagnosis. And these vaccinations are not treatments. That is an area of research, a kind of therapeutic vaccine, if you like. People are looking into that, but that isn't where we are at the moment. These are very much a preventative measure. And unfortunately in the UK, we are only vaccinating against 4 different types. Now, 2 of those cause genital warts, HPV 6 and HPV 11, and the other 2 are HPV 16 and HPV 18. So if you have one of the other 15 types of cancer causing HPV, HPV 33, HPV 45, then you are not protected against that infection. And there are vaccines that are now being developed that have that increased coverage of different viral types and more common ones that we see that cause cancer. So yeah, and unfortunately, it's not, I think it's a very effective measure in our toolbox, but it isn't the whole story.
I was just going to observe something that we are still very much in the foothills of making a difference with HPV, aren't we? Because it has, as you say, such a long sort of, I suppose it's like development time. And so if we're starting to vaccinate young men and women and girls now, we've still got decades really of this cancer taking hold. So I was just interested in the screen that you do as part of your research, Elizabeth, to find out potential treatment prospects. Is that something that you think will? It almost feels like it's a sort of side effect of what you're doing, but it's also square in the centre of your work, isn't it?
Very much. It is ridiculously a tiny component of the work, and yet I think it's going to be the most fundamental part of the work, that screen. And yeah, I do think it's going to be really revolutionary. It's an interesting one to kind of articulate. I hope that I sort of got over that we know a hell of a lot about cervical cancer and what the virus is doing in the cervix, and we just don't have that same understanding in the head and neck.
And just ask why that is. Is that because there's been an assumption that it's the same form of the virus it's causing the cancer, or it's an assumption that it just behaves the same way in a different part of the body?
It could well be that, and yet it is very much coming through in the literature that that's not the case. These are 2 very different diseases, and things that are really important for cervical cancer, say for instance the integration of the viral genome into the host, into our cells, if you like, that's a major element. Doesn't seem to be happening to the same extent in the head and neck. It is, but in very much fewer individuals. And so I sort of said, that we wanted to look at the natural history. It's because these studies have not actually been done. And what's kind of happened instead is that we've kind of made a jump. We're already treating these cancers. We've noticed that individuals are responding much better to that treatment, and so so difficult to word. Perhaps we've kind of got ahead of ourselves a little bit, and there was a clinical trial recently that looked at de-escalating treatments by using a novel immunotherapy called cetuximab, which is what we call an EGFR inhibitor, and EGFR is important in head and neck cancer. That's kind of or believed to be important in head and neck cancer. That's all we sort of need to know. So it's a really great treatment. There's much reduced toxicity, and that's what they were sort of hoping for. We'll change this regimen from the radio chemotherapy that Steve was subjected to this novel, much better, much less toxic treatment. And they anticipated, there was a trial in the UK and in the US. They anticipated similar tumor or disease control, but much reduced toxicity, so much those side effects that Steve has been describing being much reduced in those individuals that were in the cetuximab arm. And that just didn't happen. Actually, in the end, the trials, both here and in the US, had to be pulled early, because if you were in that cetuximab arm, you were had an increased chance of dying. So yes, you had fewer adverse effects. It was a less toxic treatment, but you weren't able to control that tumor. So what we are missing is that basic science. And if that study had previously been done, perhaps that clinical trial would never have happened, because we would have known that in the context of HPV in the head and neck, EGFR is not the thing to target. So the biomarkers that we hope to pull out, and the real understanding of that fundamental biology, we really hope will impact treatments really considerably.
You've explained really clearly, actually, the idea that treatments are leaping ahead without the firm foundation of understanding of what's actually happening in HPV, in throat cancer. Steve, yeah, go for it.
No, it's really interesting that Elizabeth talks about that the research isn't there yet, and the real reasons why, and it's only beginning to happen now. And it's really interesting that it took from in the UK, it took from 2008 to 2019, 11 years from girls being vaccinated to boys being vaccinated. And of course, there is a kind of anti-vax movement taking place at the moment. And I think there is a morality around this that has to be swept aside. And I feel really strongly about that. That's one of the reasons why I'm happy to talk about my experience and share my experience, because there is a morality around this. People are saying it's a judgment. People are saying, you shouldn't have been promiscuous. You shouldn't have been this. We need to be monogamous. And it's nothing to do with that. These things happen. And actually, it's really important we take morality out of this and just make sure young men and women are safe.
Could not agree more, Steve. Could not agree more. We've got, I think we might have one or two more questions. We've got a couple of minutes, if everyone's okay to hang around for a minute or two. Janet, you asked about whether there's any links between drinking hot fluids and the biology of HPV. Do you want to unmute yourself and ask the question, actually? If that's okay, from the south of France.
Yeah, I didn't have the HPV with my cancer, but I was talking to one of my friend's husbands who's a doctor, and he was saying that in France they're finding a link between people who drink their tea, their coffee and various drinks too hot, developing cancer. And so I just wondered, Elizabeth, whether you were looking at whether actually the lifestyle of the person, whether they drink hot drinks, affects the biology of the HPV virus.
That's a really interesting point. It's not a question that we have in our questionnaire at the moment, so we won't be able to draw those conclusions. But perhaps it's something certainly worth looking at for future studies, or doing an amendment and incorporating that. That's really interesting. I'll have a little look into that a little bit more.
So watch this space, Janet. We'll see what we can do about that one. Has anybody else? I've just seen Scotta. I'm sorry that you've joined late and you've missed it, but we are recording it, so you will get to catch up on our YouTube. I'll be emailing everybody with as soon as this has been edited and is beautiful and ready to be shared with the world. Has anyone else got any other questions? Because I've got one more for Steve. Oh yes, there we go. We've got a question here about from 197163. Not sure who that is, but the question was, who, for those who have already had tonsillectomies, where does the virus present? Cracking question.
This is a really, really interesting one, and I think we don't quite know the answer. I mean, I know this is a common theme throughout this evening, but there's a kind of ring of tonsils. I've been learning awful lot about my tonsil biology. But yes, we have our kind of conventional tonsils here, but within the mouth there is actually a ring. And that incorporates the base of the tongue as well, and that's another classical place for HPV positive tumours to arise. Now they don't come out kind of normally, so we don't get those bits of tissue, and it's a tonsillectomy that we will have. So we can't look at the base of tongue in the same way with our study, but within the literature, yeah, we do know that tonsillectomy does reduce the risk of HPV cancer, and people can still have head and neck cancer, HPV positive head and neck cancer, without tonsils. So there is something protective there, but it isn't a kind of case of, okay, well, we'll just whip everybody's tonsils out then, because that isn't, again, the full story.
Really interesting question, though. Thank you so much for asking it. And there's a follow-up question from Jane. Thank you. And I wonder if this is maybe slightly outside the scope of your research, but I'm wondering if you've got a view on it anyway, Elizabeth, which is, are you looking at the instance of tonsillectomy itself, and has it changed over the last 20 to 30 years?
I'm not specifically, but anecdotally, it seems that it has reduced. So whereas youngsters who would often have, say, recurrent tonsillitis would just be straight into hospital and have them taken out, that is not happening to the same extent anymore. So yeah, I don't have the data to back that claim up, but anecdotally, I think it has fallen quite substantially.
Sorry, can I just throw something in? It's also men of my age, between 50 and 60 plus. It's where that number has been spiking for several years. So for my cancer to emerge, it probably, I couldn't pin a date on it from when I got HPV and when I probably know when it started to mutate into a cancer, but that's, it's way back, and it's actually, in 2016 the spike was very high with men in their 50s. So that's quite interesting that this sits dormant for a long time.
Yeah, it is lurking. There's been a question as well about Oracle's funding. So we are funding Dr. Marsh and her team to the tune of just over £100,000, which represents 3 years of funding for the work that they're doing here. I think it's an absolute bargain, personally. It probably sounds like a lot of money, but science is actually quite expensive when you think about particularly PhD students with getting their fees and also their stipend and getting their supervision as well. So that's what we're investing in this particular study that Oracle is currently funding. 15 research programs at the moment, so that represents quite an investment for the charity, especially given these interesting times that we've had where nobody's been able to get out and do their fundraising as they have done in recent times. So we are pushing ahead. We're keeping our program open and running. It is hard work at the minute to do the fundraising, but I just want to thank everybody who has supported us over the years, and it's really it's just really heartwarming actually that you will join us on a sunny evening where there is probably beers in the sunshine calling you. Before we move on, because it is after 7 o'clock and I promised to let you go and get on with your evenings, I've got one question for Steve, and I have warned him about this question, so hopefully he's got a question and answer. Steve, I was going to ask you, just looking back, you've been on quite a journey, and I suppose what you know now is very different to what you knew then. If you had any advice for yourself right at the beginning of your treatment? Maybe that day you went into the GP and said, "Oh, that pain in my neck." What would you say to yourself?
Oh God. And I remember you asking me that night, oh, it's really, really difficult to say. I kind of, what would I say to myself? I don't know. I'd probably keep doing what you're doing, because actually it was, I think the reading I did for the Oracle in Glory at Christmas, I think probably sums it up. It was horrible. I was treated. It became horrible in another way, and then I got better. And I just say, right, if cancer's going to take you, I strongly believe if cancer's going to take you, it will take you. But actually what I was about driving forward. I wasn't going to stop, and I was going to trying to keep as healthy and as fit as possible. And I told myself way back then, keep eating, because I knew, I was told that I would lose my appetite and lose taste. I just kept eating as much as I could and kept the calories up and just pushed forward and just kept telling myself to do that, to the point where Jackie, my wife, said to me, just stop and take it easy, because I wouldn't let go. And there were times when I just had to keep doing it.
Yeah. We're getting lots of comments in the chat about that. Scott is saying, well, maybe summing it up as, it's going to be brutal, but you'll get through it, with determination. Absolutely. And Janet, you've talked about positivity.
Sorry to interrupt, but can I say, I tried as much to live in the moment. Who is it? Sorry, who said that? Was it Scott? I tried to live as much in the moment as possible. That was only the place where my head could be. Today, a friend of mine who's probably listening tonight, she said to me, and tomorrow's another day closer to recovery. And that's just the way I kept working at it. Just that, I've got X number of days before my radiotherapy finishes. What's the next stage after that? And just lived in the day, in the moment. And then so that's another day gone past. And that was the only way I got through.
Yeah, you described it to me the other when we spoke the other day as like, this was your job to get through it, and you just took it very seriously. This is it. Yeah,
absolutely.
It has been fabulous to hear from you, Steve, and you, Elizabeth, and thank you everyone for all your questions. I'm sorry if we've missed any, but if you have any thoughts, anything comes to you later, I'm sorry, Julie, that you weren't able to get in at the beginning, but if you have any questions, or you watch the video and you've got any other questions, just drop us a line. We'd be really glad to answer them. But it's just really great to be able to sort of bring what we do to life a little bit, because it doesn't really get it across, I think, sometimes just by reading something on a web page. So thank you for joining us from all corners of the world. And I'll drop you an email to follow up and share some information about where you can read about this study as well, so you've got a bit more information. And yeah, thank you for joining us, and go forth and enjoy your sunny evening. Thank you very much, everybody.